So first off, let's talk a little bit about how the brain can be changed during neuroplasticity. There are many different opportunities for us, and we do consider them opportunities. First and foremost, we have to realize there is no age-defining limits to neuroplasticity. Number one, making a diverse number of connections. That's one great way to show the brain has remapped and is plastic. Number two is to make the connections that we have more strengthened, easier to access. Number three is to actually provide more blood flow to an area of the brain that's responsible for a new task that is being learned, or to unlearn a capacity, a symptom, a fear that we want to unlearn. So we have blood flow. In addition to that, we also know that the brain has the capacity to create redundancy. So, creating similar connections to those we already have so that we have redundant pathways. So, let's review those four very briefly. New connections, novel connections, neuroplasticity. Increasing efficiency of existing connections, I can access them without difficulty and quote unquote, with my eyes closed, or like the back of my hand. We talk about this in terms of automaticity. And the third thing I said was blood flow. That's an infrastructure for neuroplasticity. And the fourth thing is redundant pathways, so that if something happens, we've got more than one way to get from one town to another. I like to think that vestibular rehabilitation was one of the true proof points for neuroplasticity in the human experience. Now, we know that it goes back decades, and we have studies with monkeys and other animals to demonstrate through probes that the brain is remoldable and mappable. But in the human experience, vestibular rehabilitation is one of the most lovely expressions of neuroplasticity, and one of the earliest, because we may have two inner ears, put simply. We also know that we could talk about them, as semicircular canals or sensory organs. Two different inner ears that used to be in agreement. And because of a problem, a trauma, an infection, or other disorder, these two inner ears are no longer in agreement. But one of the inner ears still agrees with two eyes, and all of the sensation that we get from our neck, and all of the information we get up from our feet. And through neuroplasticity, vestibular rehabilitation helps to convince the brain that we just need to change the equation. Change what's been expected from your right inner ear. It doesn't have to be the same as your left inner ear, and we recalibrate. So we're allowed to habituate and tolerate a triggering environment, a triggering activity. And now, because of the recalibration, the brain says, I know how to balance here. This doesn't cause me nausea. I no longer feel vertigo, and I don't have dizziness, through the neuroplastic reorganization that happens only when we demand it. Vestibular rehabilitation, will the brain supply it? So we think about it in demand and supply. Healthcare has advanced a significant amount since I started physical therapy school in 1988. We used to think of it as prescriptive, as therapist tells, dictates, does magical work that was evidence-based on a patient in the clinic. And now we know that that's insufficient. We know that we need to have carryover outside of the clinic for a couple of different reasons. Number one, so that we have more frequent inputs and stimulus to a brain that's ready to change. So we need an activity not to be delivered twice a week or twice a month in the clinic. We also need frequency as part of our dosage. In addition, it's important that home exercises complement clinic exercises for the very simple point of translation, so that we have what's known as a FAR transfer. So rather than everything being done in a rather sterile clinic environment where we try to imitate your home, your world, Now you're proving to yourself psychologically that it works. You're going through the same environment, your hallway, with photographs and lighting and carpeting that are in your environment and very specific. You have the confidence that you can continue that task functionally and symptom free. So again, the main thing is the home environment complements the clinic by adding frequency. But just as important, we actually have the psychological knowledge that I know I can get it done here where life matters, even when I'm done with therapy. It's an excellent consideration to know with fidelity that I'm doing my exercises correctly at home. Now, we do understand that a number one answer to this would be the exercises that you're attempting at home were prescribed for you by an expert that knows you, rather than procuring exercises off of a website or that are generalized or are Dr. Internet, if you will, based general prescriptions. So it's been prescribed for you by an expert that should know. All right, now the next step from that would be that it is common for vestibular rehabilitation activities and exercises to provoke some of the very symptoms that you are hoping to be able to resolve. That's common. But is it the right dosage? It's also very evidence-based to see that by triggering those symptoms, your symptoms only elevate a few points and only stay elevated for a brief period of time. Now, the recommendations will vary to some degree, and we're certainly not attempting to give you medical advice with this Ask the Experts section. So let's be clear. A couple of points on a scale of 0 to 10 is a common recommendation. Symptoms that I've provoked through well-intentioned exercises that go down to my resting level, which may or may not be 0, 2 minutes after I complete the exercise, is another general recommendation. The third thing to say is that, am I seeing myself get better over the long haul, a longer period of time? The only way to do that is through measurement. All of these things are amassed successfully through measurement. If you don't know that you couldn't walk to your mailbox and only feel a 1 out of 10 dizziness because you never measured it, you don't know that that feels and is a proof point of success when you've accomplished that today, for example. So when symptoms become persistent in an individual that's experiencing vertigo, dizziness, nausea, or unsteadiness, any one of the main flavors of problems that an individual may experience coming from a vestibular problem or what we call a vestibulopathy, they can become persistent because we have a predictive processing tendency or network in the brain. It's most easy to understand this by looking at an individual that endures pain. The first time you've stubbed a toe or injured your knee or tweaked your back, maybe you don't think much of it if it goes away quickly. If it lingers for a couple of moments into an hour, now your brain begins to start to wonder, how long is this going to last? You wake up with it tomorrow morning, your brain may predict that it's also going to be there the next morning. The same thing, and is true for almost any untoward or aberrant sensation you could have, tickle in the back of your throat, blurriness in your eyes, or all of the vestibular flavors, your brain naturally is going to try to predict, is it there, and devote a degree of attention to find out and check frequently, is it still there? So in solving or recovering from a persistent presentation, we need to change the brain's predictive tendencies and give it some surprising successes. Small doses of an activity where you would have predicted, if I get in that back seat and have to ride in the car, I'm going to have nausea. But a small dose of it that's successful, that doesn't trigger you, starts to unwind neurons that fire together, nausea, wire together, I'm in the back seat of a car. That's a short answer to a very long dilemma. Providers that are interested in and have studied up on or have amassed a degree of experience or excellence in vestibular rehabilitation are very likely to have registered with the Vestibular Disorders Association. So the VITA website is a very easy one-stop shop to look for an excellent provider in your area. That would be the first thing to look for. Now, we understand that vestibular experts can come across many professions, so please don't think it just has to be a physical therapist or an occupational therapist. Individuals that are interested, that have amassed expertise, can come across many different populations and understand that each one of those professions may have a different designation or degree or training. But going to the VITA website should always be your best and first solution. So when I was working with a patient in the clinic today, it came upon me the notion of prehabilitation. This is not a novel concept, but I'm going to give a novel treatment to it. The individual that I was working with did not have a known vestibulopathy or problem of the vestibular system across all of its organs and nerves, etc. But I thought to myself, it's important that as we age and as we've recovered from a vestibular problem, in both of those situations, you may be symptom free. And those are equally important times to still expose your body to head rotations as you walk, to focusing on an object as you turn your head side to side, to eyes open and eyes closed, to firm conditions and compliant or cushioned conditions, to busy backgrounds and to simple backgrounds. And when you think about that from a prehabilitation, you think, okay, I want to have some redundancy. And we think about certainly persons that lose cognitive skills. The higher they start their cognitive skills before they have dementia, the more functional they remain. The stronger you are before you have an illness, the more functional you remain despite that illness. So we think about the importance of exposing ourselves to getting underneath that kitchen sink and looking up at that plumbing, even if we are healthy, giving yourself those varied experiences. And even if you've recovered, reminding your brain how to deal with those movements, conditions, and activities for your continued health.